In this age of fast forward, to regularly rewind, analyze, and to get your basics right again in all aspects of life is actually being ahead of time. So, as we enter into the first year of MBBS, we build ourselves brick by brick. Each and every brick is very important. Each and every subject is very important. If any brick is loose, or if we remove any brick from this building, there are chances that the whole building might fall down. So, here comes the significance of integrated sessions. Hello, all. I'm Dr. Manisha Budhiraja, your faculty for ENT.
Hi, all. I'm Dr. K. Raviraj, your anatomy faculty. So welcome to the integrated session of anatomy and ENT. As you know already, anatomy is very much essential for all the surgical specialties. And now in the case of ENT, if you are strong in head and neck anatomy, almost 50% of your work is done. And today, I'm extremely happy to have a session with Manisha ma'am.
So let us start with the session and let us start with the first question. A 41-year-old man presented to the emergency with a one-day history of fever, headache, and right periorbital and midfacial swelling. The day prior to the onset of its symptoms, he had attempted to burst a furuncle in the inner margin of his right nostril. On examination, he was conscious, though ill-appearing, and was febrile. He had marked right-sided facial and periorbital swelling with chemosis. There was loss of ocular movements in the right eye. The visual acuity and color vision were normal. The left eye showed chemosis and loss of abduction. There is periorbital sensory alteration and reduced corneal response. There was no other neurological deficits. Past medical history is significant for a history of diabetes mellitus for the past 10 years. Write true or false about this patient. So here we have a patient who had a furuncle of the nose and he tried to burst it, following which he has developed these symptoms of fever, headache, periorbital swelling, and loss of ocular movements in both the eyes. So what do you think this is? Is it an orbital complication which has happened following a nasal vestibulitis, or is it something else? Yes, just look again. The acute presentation, the bilateral presentation, both the eyes are involved. There is loss of ocular movement in both the eyes, loss of corneal anesthesia. All this suggests that no, this is not orbital cellulitis. This is cavernous sinus thrombosis. So, sir, can you please tell us how this can happen?
Yeah, ma'am. So now from the history, the patient is having infection in the danger area of face. And in the question, they also given that the loss of ocular movements in the right eye and there is loss of abduction, which means that third nerve, fourth nerve, and the sixth nerve is affected. Now, see this diagram. This is the danger area of face. So the danger area of the face include the upper lip and the lower part of the nose because it is drained by facial vein. So any infection in this area, now the infection will be going to the cavernous sinus. Now what is the root, sir? Now we have the connection between the facial vein and the cavernous sinus. Now we have two routes of communication. One is facial vein and then angular vein and then superior ophthalmic vein, which is a tributary and the communicating channel to the cavernous sinus. This is one route. Now we also have another route from the facial vein, which goes to deep facial vein and then pterygoid venous plexus via emissary vein, which in turn goes to cavernous sinus. Now out of these two routes, now in the exam, they will ask you which is the most common communicating channel between the facial vein and the cavernous sinus. Please remember the answer is superior ophthalmic vein. That is the most common route. One time they gave this question. Right. Now we see some details about the cavernous sinus. Now cavernous sinus, I think you know, it is a paired venous sinus situated on either side of the body of sphenoid. Now see the diagram here, it is a cut section. So this is our sphenoidal air sinus. And just above that, we are seeing one small gland there, that is our pituitary gland. Yes. And the cavernous sinus is showing in dotted line. Now what are the contents? What are the structures passing through the cavernous sinus? Yes, now you are seeing one large artery there, that is our internal carotid artery. And below that, you are seeing one nerve, that is our abducent nerve. So sixth nerve is passing through the cavernous sinus. And see this diagram. Now this is a diagram showing the lateral wall of the cavernous sinus. The lateral wall of the cavernous sinus, we have three nerves: third nerve, fourth nerve, and the trigeminal division left. First one, that is ophthalmic nerve. So third nerve, fourth nerve, and ophthalmic nerve in the lateral wall. Please remember, maxillary nerve is not running in the lateral wall. In the old edition books, they mentioned maxillary nerve in the lateral wall, but now recent 41th edition and 42nd edition Gray's Anatomy, they are saying that maxillary nerve is not running in the lateral wall of cavernous sinus. Now, I have one question for you. Third nerve, fourth nerve, sixth nerve, and the ophthalmic nerve, they are related to the cavernous sinus. Yes. Now they are also passing through one more structure. What is that? Yes, very good. That is superior orbital fissure. So superior orbital fissure, again third nerve, fourth nerve, sixth nerve, and the ophthalmic nerve will be passing. So same structures are related to the cavernous sinus. Now see the option A. The patient has developed orbital cellulitis. Now ma'am, I have one doubt. How to differentiate the orbital cellulitis and the cavernous sinus thrombosis, madam? Third nerve, fourth nerve, sixth nerve, and ophthalmic nerve. The same structure is passing to the superior orbital fissure and the cavernous sinus. And how to differentiate orbital cellulitis and the cavernous sinus thrombosis, ma'am?
Yes, sir. That is a very important question that our students are asked. The presentation is given and they are supposed to diagnose whether this is a patient of orbital cellulitis or it is a patient of cavernous sinus thrombosis. So in orbital cellulitis, always the progression is very slow. It is a gradual progression, which means that the patient will first have periorbital edema. Later on, it will progress to chemosis, proptosis, and then there will be involvement of the nerves leading to loss of ocular movements. And when there is involvement of the nerves, all the nerves, third, fourth, sixth are involved together, which means that all the movements of the eye will be gone together. There will be total ophthalmoplegia. Whereas in cavernous sinus thrombosis, there is a very abrupt onset. As it was in this patient, there was only a one-day history of high fever, headache, and then suddenly there are so many orbital findings. And there is gradual ophthalmoplegia. There is progressive ophthalmoplegia. The presentation is abrupt, but when the nerve involvement occurs, it is progressive. The earliest to be involved there is the sixth nerve. As we are seeing in this patient, the other eye, the loss of abduction has occurred. So this is again another important question that is asked from a student, that in cavernous sinus thrombosis, which is the earliest nerve to be involved? So maybe the patient has just presented with a high fever, headache, and just diplopia because of loss of abduction. Again, that can be a cavernous sinus thrombosis. And as we are seeing here, both the eyes are involved. Since the cavernous sinus intercommunicate on both the sides, so cavernous sinus thrombosis, maybe to start with it is unilateral, but later on it becomes bilateral. Whereas orbital cellulitis is always unilateral. And as we saw that in the cavernous sinus, laterally we have the trigeminal nerves. So because of compression of that, there is paresthesia in the distribution of trigeminal nerve. That signifies again a cavernous sinus thrombosis. Again, that feature was present in this patient. So these are the features which will help us to differentiate whether it is an orbital cellulitis or it is a cavernous sinus thrombosis. So this is not a orbital cellulitis. This is a case of cavernous sinus thrombosis.
Yeah, ma'am. Thanks. So now see the option B. The periorbital sensory alteration is because of involvement of third nerve. No, that is false. Now this is because of the involvement of which nerve? Yes, very good. Ophthalmic nerve. Now, in the case of third nerve involvement, I told you already, the third nerve involvement will have three features. What are those? Please remember the mnemonic. I told you already, P, PD, and PDO. The patient will have ptosis, and the patient will have pupillary dilatation, and the eyeball will be down and out. I hope you remember this mnemonic. Yes, very good. So, option B is false. The route of this infection from the nose is through maxillary vein. Again, this is false. Why? Which vein? Yes, fascial vein. From fascial vein to superior ophthalmic vein to the cavernous sinus. And another route is via deep fascial vein and pterygoid venous plexus.
So the fourth choice we have here is the patient should be taken up for surgery immediately. No, in cavernous sinus thrombosis, the primary management is medical. You have to admit the patient and give the patient high dose of IV antibiotics. Broad spectrum antibiotics is what we give the patients here. Even if it is a patient of orbital cellulitis, there also the primary management is always medical. And we go for surgical management in cases of orbital cellulitis in two cases. One, when there is an orbital abscess, and second, when there are features of optic nerve compression. So how do we know that the optic nerve of this patient is getting compressed? Yes, by checking the visual acuity, by checking the color vision. So these are the things that we look for in any patient, as it was mentioned in this case also, that the visual acuity is normal. So every point that is mentioned in the question has some significance. So if this is there, then we go for surgical management. Otherwise, the primary management is medical for both of them.
So to summarize, please remember the relation of the cavernous sinus. Cavernous sinus is located on either side of the body of sphenoid bone. Yes. Now, where is sphenoidal sinus? The sphenoidal sinus is on the medial side. Pituitary gland again on the medial side. And what are structures in the lateral wall? Third nerve, fourth nerve, and the ophthalmic division of the trigeminal. Yes. Now, what are structures passing through the cavernous sinus? Internal carotid artery and the abducent nerve. And please remember the tributaries also: superior ophthalmic vein, inferior ophthalmic vein, central vein of retina, sphenoparietal sinus, superficial middle cerebral vein. And please remember the intercavernous sinus. We have two, the anterior and posterior intercavernous sinus, that communicate the cavernous sinus of either side.
So what is the clinical significance of knowing this venous drainage? Yes, if there is any patient who has come to you with even a minor infection of the dangerous area of the face, like a furuncle of the nose, a nasal vestibulitis, you should not take it lightly. It should not be treated like a furuncle anywhere else where you can wait and watch. You will immediately start the patient on antibiotics. Yes, can you tell me which organism you will focus the antibiotic on? Yes, very good, staph. So we can give which antibiotic? Yes, we can give amoxiclav here. So you will start the patient on antibiotics. You will ask the patient not to fiddle with this furuncle as this patient did in the question. Yes, because these veins are valveless. So this infection can go retrograde very easily. You're pushing it. You are helping it to go retrograde into the cavernous sinus. And any immunosuppression of the patient, like in this patient, it was a diabetic patient, has to be taken care of. Now, many times you will also see that there are patients of sinusitis who are presenting like this. So yes, sinuses also have this common supply, common venous drainage with the eye and the cavernous sinus. So any patient of sinusitis can also present with orbital cellulitis or with cavernous sinus thrombosis, and these are very common questions that are asked. So if there is any sinusitis patient who has presented to you with a complaint like this, who has come to you with swelling of the eye, don't just think that this can be an insect bite. Don't just think that this can be an allergy. Orbital complications are the most common complications of sinusitis. So always keep caution, always be cautious, and rule out orbital complication. And it might also be present that the patient following sinusitis has come with fever, headache, and just one feature, that is loss of abduction of the eye. So that can be the early feature of cavernous sinus thrombosis. So when you know all these things, you will not miss any patient. And this is a life-threatening condition. So if there is a cavernous sinus thrombosis that you have diagnosed, you will have to admit this patient immediately. You will have to start this patient on IV antibiotics. Yes, get an MRI done. See how much is the involvement. Immediately start the patient on IV broad spectrum antibiotics. So that is why it is very, very important to know these connections. And since it is a life-threatening emergency, this is very commonly asked in your exams. And yes, you know how to differentiate between orbital cellulitis and cavernous sinus. That is again another thing that is asked in your exams. So starting with the case 2, following intact canal wall surgery through the facial recess area for squamosal CSOM. So what is squamosal CSOM? Yes, cholesteatoma. Of the right ear, a patient comes to you with the complaints of loss of taste on the right side of tongue. There is no other complaint. Mark the true statement. So here you are operating a patient for cholesteatoma, and following that surgery, what you're seeing is that this patient has developed loss of taste. So, sir, can you please tell us what the facial recess area is, which has been mentioned in this question here?
Yeah, ma'am. So now see the diagram here. Now this is the diagram of middle ear. So we know that middle ear and inner ear is present inside the petrous part of temporal bone. And now we remove the tympanic membrane. So tympanic membrane forms the lateral boundary for the middle ear. And now in the diagram, you are seeing the anterior wall, posterior wall, and roof, floor, and the medial wall. Yes. Now see the posterior wall. Now in the posterior wall, we are seeing the facial nerve canal. Now this is the facial nerve canal, and we also seeing the pyramidal eminence, which contains the stapedius muscle. So now just below that, you are seeing the nerve also, chorda tympani nerve. So now I'm going to zoom this image. So see here. Now if I zoom this image, now this is what you see there. Yes. Now this is the facial recess. Now what is facial recess? The facial recess is a small groove which lies between the pyramid with the facial nerve and the annulus of the tympanic membrane. Now what is the boundary of facial recess? Now medially we have the facial nerve. Laterally we have the tympanic annulus with the chorda tympani nerve. And the chorda tympani nerve runs medial to the tympanic membrane. Yes. Now what is the superior boundary? The superior boundary is the short process of incus. Now, ma'am, what is the importance of this facial recess? Now, why we have to know about the facial recess anatomy?
So yes, this facial recess is a very crucial area for us in mastoid surgeries. This is an area where we make an opening which acts as a communication between the mastoid and the middle ear. So when do we make this opening? When we make this opening, as we are seeing here in this picture, in this diagram, we have made an opening in the facial recess area. This can act as a communication between the mastoid and the middle ear when we want to remove the disease from the middle ear through the mastoid, as we do in intact canal wall surgery. So when do we do intact canal wall surgeries of mastoid? Whenever there is a limited disease, a squamosal, a scholestoma, which is limited, it is not very extensive. In the mastoid and middle ear, we have removed the disease from the mastoid. Now we want to remove the limited disease from the middle ear. So we have to go through the common wall, through the posterior wall. So since the disease is limited, we do not want to completely remove this common wall to access the middle ear. We go for a conservative approach. We make a small opening on the posterior wall in this facial recess area and remove the limited disease of the middle ear, and this is what is known as intact canal wall surgery. And this communication we can also use when we want to introduce electrodes of cochlear implant into the middle ear. We know that electrodes of cochlear implant we actually have to pass into the inner ear, but we are passing it through the mastoid. So it will first have to be passed into the middle ear. So to pass it into the middle ear, we use this communication, we use this opening, we make a posterior tympanotomy in the facial recess area. Yes, here we are seeing the facial nerve. That's the medial boundary. This is the chorda tympani, the lateral boundary. And here this is the fossa incudis, on which is present the short process of incus. So this can be done for, yes, as I told you, intact canal wall surgeries or for cochlear implantation. And here it is again asked that it is passed, the electrodes are passed into the middle ear through, then the answer will be facial recess, into the inner ear through, then the answer will become round window. And yes, when we make an opening here in the facial recess area, the round window is very easily visible. So it is very easy to pass the electrodes through the round window into the inner ear. And this picture was a picture-based question of your exam, where the opening, the upper opening was marked and was asked, what is this opening? So yes, that is the opening of the facial recess area.
Yeah, thanks, ma'am. Now see the option. There is injury to the mastoid segment of facial nerve, and option B, there is injury to the chorda tympani. Now we know already chorda tympani is a branch of facial nerve which is arising from the mastoid segment only. So now option A and B almost they are similar. Now ma'am, which is the best answer, ma'am? Option A or option B?
Yes, now we know that the mastoid segment can be injured, and mastoid segment, if injured, automatically the chorda tympani, which is a branch of the mastoid segment, will be affected. But only the chorda tympani will not be affected. The mastoid segment, when it comes out through the stylomastoid foramen, it supplies all the facial muscles. So once the mastoid segment is injured, beyond that, everything will go. So there will be complete palsy of the face of one side, which is not mentioned in the question, which means that there is specifically injury only to the chorda tympani, not to the mastoid segment. So you tell the patient this is a normal finding after this surgery. Option C, is that true? No, this is not a normal finding after surgery. When we operate, we are after surgery, we are supposed to have all the nerves intact. Yes, this is a normal finding after with surgery, after canal wall down surgery. Whenever we do canal wall down surgery, we lower the common wall between the mastoid and the middle ear, external aortic canal, and the mastoid. We remove this common wall completely up till the descending part of the facial nerve, which means that we always sacrifice the cauda tympani. So there it is a normal finding. It is not a normal finding here.
Now see the option D, injury to facial nerve at the stylomastoid foramen. The facial nerve, after coming out of the stylomastoid foramen, now see the diagram here. Now this is the stylomastoid foramen. The facial nerve, after coming out of stylomastoid foramen, the facial nerve will give only motor branch, which gives branch to posterior belly of digastric, very good, which gives branch to stylohyoid muscle, yes, very good, which also gives some branch to auricular muscles, yes, and also gives a motor branch to face. What are those? That is a temporal branch, zygomatic branch, buccal branch, marginal mandibular branch, and the cervical branch. And this arrangement is called as pes anserinus pattern. So option D, this is false. Okay.
So coming to option E, injury to glossopharyngeal nerve at the tympanic plexus. Glossopharyngeal, does it supply the taste of the tongue? Yes, taste. Yes, the posterior one third of the tongue, the main supply for taste is the glossopharyngeal nerve. But will an injury to the tympanic plexus lead to loss of taste? That is through a separate branch, the pharyngeal branch of glossopharyngeal. It is not through the tympanic plexus. So can you please tell us, sir, about the tympanic plexus?
Yeah, ma'am. Now see the diagram here. Now this is the medial wall. You are seeing the promontory. Now over the promontory, we are seeing the tympanic plexus. So please remember, the tympanic plexus is formed by the tympanic branch of glossopharyngeal nerve and the carotico-tympanic nerve. Carotico-tympanic nerve is nothing but it is a sympathetic plexus. Okay. So now see here. Now see this diagram. This is the tympanic plexus. Yes. The tympanic plexus, which in turn continue as lesser petrosal nerve. Lesser petrosal nerve is passing through one foramen. Which foramen? Yes, very good. Foramen ovale. Yes. And the lesser petrosal nerve, which in turn relates to one ganglion. What ganglion? Yes, otic ganglion. Very good. Now, after relaying to the otic ganglion, the auriculotemporal nerve, which carries post-ganglionic parasympathetic fibers to the parotid gland. Yes, lesser petrosal nerve carries pre-ganglionic parasympathetic fibers to the parotid gland, whereas auriculotemporal carries post-ganglionic parasympathetic fibers to the parotid gland. So during parotid surgery, the surgeon mistakenly may damage the auriculotemporal nerve. Now in that case, the auriculotemporal nerve will regenerate, which in turn joins with the great auricular nerve, which in turn result in Frey syndrome. Now ma'am, do we have any surgical treatment for the Frey syndrome?
Okay, so what is Frey syndrome is that whenever the patient eats, along with salivation from the parotid, there is also sweating in this area of the skin overlying the parotid. So during parotid surgeries or during surgeries in this area, when the auriculotemporal nerve gets cut, now during regeneration, what happens is along with now supplying the parasympathetic part of the parotid, there is aberrant regeneration and the nerve comes up to supply the sympathetic sweat glands of the skin overlying the parotid. So now what happens is, so here we have the skin overlying the parotid. So now this nerve is supplying both the parotid as well as aberrantly to the skin overlying the parotid. So now when the patient eats, along with salivation from the parotid, there will also be sweating from the skin overlying the parotid. So what we want to do is we want to transect this connection which is coming to the skin. So for that, what we can do is the best is a non-operative management, that is to inject the botulinum toxin in the sweat glands of this area of the skin, or surgically also we can raise the skin flap so that the nerve gets transected. The nerve fibers which are coming up to supply the sweat glands, they get transected, and we can implant something just below the skin. That can be a muscle flap, that can be a fascia graft, and we can replace it back. So now the nerve fibers have got transected. And yes, here in significance to the tympanic plexus, why is the Frey syndrome important? We saw that through the tympanic plexus, through the lesser petrosal nerve was coming the parasympathetic part of the supply of the parotid. So earlier what used to be done was, for the management before the invent of botulinum toxin and these surgical management, simply tympanic neurectomy used to be done. That is still done nowadays when there is no benefit from these measures. So in now you know why tympanic neurectomy will benefit these patients.
Right. So now the answer. So now answer for this question is option B is right. Yes. So now to summarize, so we have to know the boundaries of facial recess. Now facial recess is a small groove. Medially you have the facial nerve, and laterally you have tympanic annulus with the cauda tympani nerve, and superiorly you have the short process of incus. And please remember the tympanic plexus is formed by the tympanic branch of the glossopharyngeal nerve and the caroticotympanic plexus.
Yes, and that is what is known as the Jacobson's nerve. That is again a question of your exam. Now, clinically, the facial recess is a very, very significant area of the posterior wall of middle ear. The surgery that we do here is what is known as making an opening, that is posterior tympanotomy, and that is an intact canal wall surgeries, and also to introduce electrodes of cochlear implant. And this middle ear, the middle ear surgeries, and as you're seeing here, the facial recess, this picture that you saw is a very, very magnified view. So which means that you can make out that a lot of surgical expertise is required, which means your anatomy to operate the middle ear should be very, very nice. So starting with the third case, a 17-year-old male presents with the complaint of recurrent epistaxis for the last 6 months. Endoscopic examination of the nose showed a red vascular mass in the right nostril. A CCT was performed which showed an enhancing mass filling the right nostril and Holman-Miller sign. Also, there was some extension of the mass intracranially through the marked foramen. True about this is, so here we are seeing a young male with recurrent epistaxis. We know any young male with recurrent epistaxis should be investigated for, yes, for angiofibroma. And yes, the endoscopic picture is matching with it. A red vascular mass is what we are seeing. The CCT is the diagnostic for angiofibroma. We already know that. Is biopsy done in angiofibroma? No, never. So CCT is diagnostic here. And what is the sign that is diagnostic is already given here, the Holman-Miller sign. Let us quickly have a look at how the Holman-Miller sign looks like. So here we are seeing this area. This is the sphenopalatine foramen area. We can compare it with the opposite side. This here is the foramen area, which is normal here. And this is where the angiofibroma arises from. And then it comes most commonly into the nasal cavity. Here we can see the mass, the enhancing mass filling the nasal cavity, going to the nasopharynx. And laterally from the sphenopalatine foramen, it is going into the sphenopalatine fossa, as we can see here. From the sphenopalatine foramen, it has gone into the sphenopalatine fossa. It has completely filled the fossa, pushing the posterior wall of antrum anteriorly. And this pushing of posterior wall of antrum anteriorly is what is known as Holman-Miller sign or antral sign. And this is diagnostic of angiofibroma. So this is a case of angiofibroma that we have here. But yes, what is not asked is the diagnosis. What is asked here is true about the marked foramen. So, sir, can you tell us what this foramen is?
Yeah, ma'am. So now to see the boundaries of the sphenopalatine fossa, first you have to know some basic anatomy about the infratemporal fossa. Now, infratemporal fossa, it is nothing but a fossa present below the temporal fossa, right? Now, in this diagram, can you see the temporal fossa here? Yes. Now, this is the lateral view of the skull. So, this is the temporal fossa, yes. And just below that, we have the infratemporal fossa, yes. Now, what is the boundary of infratemporal fossa? See, infratemporal fossa boundaries, now we remove the mandible. Yes, this is a mandible. Now we remove the mandible, that will form the lateral boundary for the infratemporal fossa. Now medially, we are seeing the lateral pterygoid plate, and the roof is formed by the sphenoid bone, and anteriorly it is formed by maxilla bone. Now what we have to know is, now we have to know about the pterygomaxillary fissure. Now why we have to know the pterygomaxillary fissure, sir? So pterygomaxillary fissure, which in turn communicates the infratemporal fossa to the sphenopalatine fossa, otherwise known as pterygopalatine fossa. Now see this diagram. Now this is a diagram showing the pterygomaxillary fissure. Now can you see the round here, dotted round, red line? Yes, that is a pterygomaxillary fissure. Now if you go inside the pterygomaxillary fissure, then you will be seeing one fossa there. That fossa is called pterygopalatine fossa. So Pterygopalatine fossa, it is a fossa present between maxilla bone, sphenoid bone, and the palatine bone. Is that clear? Yes. Now see the boundaries of the sphenopalatine fossa, which is otherwise known as the Pterygopalatine fossa. Now, just now I told you the Pterygopalatine fossa, it is a fossa present between the maxilla bone, sphenoid bone, and the palatine bone. Now, can you see the bone here? That is the perpendicular plate of palatine bone. Now, between these three bones, now we have one fossa, that is the Pterygopalatine fossa. Now, where it is situated? It is situated below the apex of the orbit. Is that clear? Right. Now, what is the boundary for the Pterygopalatine fossa? Now, anteriorly, what you are seeing here, yes, this is the maxilla bone, posterior surface of maxilla. Now, superiorly, you are seeing the sphenoid bone. Yes. Now, behind, you are seeing the root of the pterygoid process. This is the posterior side. Behind, that is the root of pterygoid process. Now, what is on the medial side? Now, medially, we have, see here, medially, we have the perpendicular plate of palatine bone. This is the perpendicular plate of palatine bone forms the medial boundary of the sphenopalatine fossa. Is it clear? So now boundary is over. Now next important thing, you have to know the contents of this fossa. Now what are the contents of the Pterygopalatine fossa? Please remember the three main things. Number one, maxillary artery. Number two, maxillary nerve. And number three, Pterygopalatine ganglion or sphenopalatine ganglion. Is that clear? Now next, what are the communications we have? Now communications, we are seeing the foramen in the medial wall. That is, can you see the foramen here? Yes, that is our sphenopalatine foramen. So sphenopalatine foramen. Yes. Now, we know already the maxillary nerve is divided into three parts by means of which muscle? Yes, very good. Lateral pterygoid muscle. So three parts of maxillary artery. What are those? Mandibular part, pterygoid part, and the pterygopalatine part. Yes, the third part of maxillary artery is present in the pterygopalatine fossa. Yes. Now, the maxillary artery third part will give one branch. That branch is called sphenopalatine artery, that is passing through which foramen? Sphenopalatine foramen. Yes, very good. Now, sphenopalatine artery goes and supplies the nasal cavity. It gives branch to the nasal septum, and it also supplies the lateral wall, that is lateral nasal branch. Is it clear? Yes. So now, so superiorly, the Pterygopalatine fossa communicating with the orbit via inferior orbital fissure. Now, can you see that? Yes. This is the inferior orbital fissure. Now, through which the Pterygopalatine fossa communicating with the orbit. Now, the maxillary artery, again, third part, will give one branch, will be passing through that. What is the name of the branch? Yes, infraorbital artery, that is passing through inferior orbital fissure. Very good. Now, in the posterior wall, we have two more foramens we are seeing here. Now, we remove the maxilla bone and we remove the palatine bone, and now we are seeing the posterior wall, posterior boundary of sphenopalatine fossa. Is that clear? Now, in the posterior wall, we are seeing two foramens here. This is A and this is B. Now, what is A? A is foramen rotundum. Yes, very good. That is foramen rotundum. That is a round foramen. And that is a question they gave in last INACET exam, 2020, November INACET exam, they gave this. Identify the marked foramen. Very easy question. Yes. Now, B, that is the pterygoid canal. Right? Now, can you identify the sinus here? Now, this is sphenoid bone. In the body of the sphenoid bone, you are seeing the sinus there. That is the sphenoidal air sinus. Now, where is the pterygoid canal? Pterygoid canal, it is in the floor of sphenoidal sinus. Yes, very good. Now, again, the maxillary artery third part will give one branch, and that branch will be passing through this canal. So, what is the name of the artery? Yes, very good. Artery to the pterygoid canal. Now, see the pterygoid canal here. Yes. Now, this is a pterygoid canal, and the pterygoid canal transmit the nerve to pterygoid canal and the artery to the pterygoid canal. So, the nerve to pterygoid canal is formed by the joining of greater petrosal nerve and deep petrosal nerve. Greater petrosal nerve, it is a branch of, yes, fascial nerve. Very good. Again, deep petrosal nerve is a branch of, it is a sympathetic plexus over the internal carotid. Very good. Now, the Vidian nerve or nerve to pterygoid canal, which in turn end in one ganglion, that is called as Pterygopalatine ganglion or sphenopalatine ganglion. Now, please remember the pterygopalatine ganglion or spinopalatine ganglion, it is the largest peripherally placed parasympathetic ganglion. Now, these are the basic details you have to know about the spinopalatine fossa. So now see the question here. The marked foramen is a foramen rotundum. Yes. Now see the option. The marked is a foramen through which the maxillary nerve enters spinopalatine fossa. Yes, this is true. Option B, marked as a pterygoid canal. No, it is false. Option C, it is a connection of spinopalatine fossa with the orbit. Yes, this is false. Spinopalatine fossa communicating with the orbit via inferior orbital fissure. Yes.
And the D choice we have here is preoperative radiotherapy should be given to this patient. Now, we know that angiofibroma patients are young, and in young patients, radiotherapy is never the first choice. It is not given, it can induce second tumors. So, the main management of patients of angiofibroma is surgical excision. What is the indication of radiotherapy in patients of angiofibroma? Only when the tumor has gone intracranially and it has become unresectable. If it has gone intracranially and that is minimal invasion, then we can still remove it surgically. But if it has become unresectable because of his additions intracranially or because of the blood supply that it is getting from the intracranial vasculature, when it becomes inoperable, only then we go for radiotherapy. We never go for pre-op radiotherapy. In the preoperative period, to decrease the vascularity of the tumor, we do go for pre-op embolization. And now let me ask you, when I say that pre-op embolization, was a question asked in your exam that what is the main arterial supply of angiofibroma? Now, even if you do not know what the main arterial supply of angiofibroma is, you know where it is present. You know what the artery there is. So what is the main arterial supply? Is that the maxillary artery. And now if I ask you that the angiofibroma can go intracranially through which foramen? Yes, we know this is a benign tumor. This is not a malignant tumor that will erode everywhere. It is a benign tumor, so it will go everywhere through the natural foramina, the natural fissures. So that is why these connections are very important. If it goes into the orbit, it is going from where? Through inferior orbital fissure. If it is going intracranially, it can go through the foramen rotundum. It can go through the Viridian canal. If it is going into the infratemporal fossa, from where is it going? Yes, it will go through the pterygomaxillary fissure, always sir has shown us very beautifully. And when we know this anatomy, it becomes so simple for us to remember the staging of angiofibroma. The Radowski staging, which was asked in an exam, and that is also the deciding factor for whether we go for radiotherapy or not. So what stage of Radowski's do we go for radiotherapy? So let us just see. We know that this tumor is arising from the sphenopalatine foramen, and most commonly it will go into the nasal cavity. So that constitutes the stage 1 of Radowski's classification, and that is 1A. Now, from the nose, it can go into the sinuses. If it goes into the sinuses, either the maxillary sinus or posteriorly from the nasopharynx, it can go into the sphenoid sinus. If it goes into any of the sinuses, that constitutes the 1B. Now, when it goes laterally, the lateral spread is what is 2. So, which means that when it has gone into the sphenopalatine fossa, that is 2. When there is minimal spread into the sphenopalatine fossa, that is 2A. When the sphenopalatine fossa is completely filled, as it is in this case, pushing the posterior wall of antrum anteriorly and going into the orbit also, yes, to the inferior orbital fissure, that is 2B. And when it goes further laterally into the infratemporal fossa, that is 2C. So all the lateral spread is 2. And when it goes intracranially, that is 3. 3A is when there is minimal intracranial extension, and 3B is when there is extensive intracranial extension with or without cavernous sinus, which means that there is very extensive intracranial extension. So in which one will you go for radiotherapy as the primary management? Yes, in the 3C. In the 3C here, the primary management is radiotherapy. Rest all the primary management of angiofibroma is always surgical excision. So that is why when surgery becomes the primary mode of management, you can understand that the anatomy becomes so important. The surgeon has to know exactly where he is moving, and even if the tumor has gone into the infratemporal fossa where he has seen on CT that the extension is minimal, if he knows where exactly the foramen rotundum is, where exactly the median canal is, he can easily remove the tumor from these foramen without damaging and without leading to a lot of blood loss.
So now the answer for this question is option A is the answer. Option A is true. So to summarize, so please remember the boundaries of sphenopalatine fossa. So any tumor in the nasal cavity via sphenopalatine foramen, it can come to the sphenopalatine fossa or pterygopalatine fossa. So from there, it goes to the orbit via inferior orbital fissure. So from this sphenopalatine fossa, it can go to the middle cranial fossa via foramen rotundum and via a pterygoid canal. And laterally, tumor can come to the infratemporal fossa. Now from infratemporal fossa, communicating below, actually infratemporal fossa, which is open below, which is communicating with the tissue spaces around the pharynx and the esophagus. So please remember the boundaries and communications of the sphenopalatine fossa, then the rest of things will be very easy for you.
Now, coming to the clinical significance of the sphenopalatine fossa and the sphenopalatine foramen, as sir has very beautifully told that this sphenopalatine fossa is the area where the major vessels and nerves that supply the nose and the sinuses are placed, and they enter into the nose through the sphenopalatine foramen. The main arterial supply, the sphenopalatine artery, the nerve supply, the sensory nerve supply, all of them enter into the nose through the sphenopalatine foramen. So this sphenopalatine foramen is the area through which we can anesthetize the nerves which are present in the sphenopalatine fossa. So how we can do that? Yes, we can do that either by injecting anesthetic through the sphenopalatine foramen, or we can place a nasal applicator with anesthetic at the sphenopalatine foramen area, and this anesthetic will seep into the fossa, anesthetizing the nerves there. Also, since the artery, the sphenopalatine artery enters the nose through this foramen, the sphenopalatine artery is the artery of epistaxis. It is the main artery involved in anterior as well as posterior epistaxis. And be it anterior epistaxis or posterior epistaxis, if we have to ligate, then this is the first artery that we ligate, and that is what is known as the tespal. Yes, so what is tespal? So that is what is known as tespal, transendoscopic sphenopalatine artery ligation. So that is done endoscopically here. And also what we need to know here is that this is the most common site of origin of the most common benign tumor of the nasopharynx, that is angiofibroma. And how the angiofibroma will spread, and what is the arterial supply, and what is the management, we have just dealt with. Each and every point here is a question that is asked in your exam. So when you know this anatomy, all of the angiofibroma and all this related anatomy becomes so simple for you to remember. So we have the next case here. A 30-year-old singer underwent left hemithyroidectomy. Following surgery, she complains of inability to sing high notes. You are asked to do an endoscopic examination of the larynx, and you report that the left vocal cord is bowed and lax during phonation, especially while singing high notes. The vocal cords are moving normally with respiration. There is no complaint of aspiration. True about this patient is. So here, this is a patient following thyroid surgery has come to you with some complaints of voice. So before we go to decipher what this palsy is, which nerve has got injured following thyroidectomy here. So sir, can you please tell us about the nerve supply of the larynx?
Yeah, ma'am. So now see the diagram here. Now this is the vagus nerve. Yes, vagus nerve will come out of the cranial cavity to the jugular foramen. I hope you know that. Now in the base of skull, now the vagus nerve will give the superior laryngeal nerve. So superior laryngeal nerve is arising from vagus nerve in the skull base itself. Now in the carotid triangle, that is at the upper border of the greater horn of the hyoid bone, now the superior laryngeal nerve in turn divided into internal laryngeal nerve and the external laryngeal nerve. Now please remember, internal laryngeal nerve is a sensory nerve and the external laryngeal nerve is the motor nerve. So internal laryngeal nerve supplies the mucosa of the larynx above the vocal fold, and the external laryngeal nerve, it is the motor nerve, supplies only one muscle, that is the cricothyroid muscle. Cricothyroid muscle, please remember, that is the tensor of the vocal cord, and that muscle also do mild adduction. Now what about the recurrent laryngeal nerve? One more nerve you have to remember. Now the recurrent laryngeal nerve, the right and left nerve have different codes. Now please remember, the right recurrent laryngeal nerve is arising at the level of subclavian artery, whereas the left recurrent laryngeal nerve is arising at the level of arch of aorta. So now out of the right and left recurrent laryngeal nerve, which nerve is most commonly affected? Very often you are getting this question. Please remember the left nerve is affected more than the right nerve. Why, sir? Because the left nerve have a course in both in neck and also in the mediastinum, in the superior mediastinum. Right. Now, in the case of thyroid surgery, which nerve is most commonly affected? Now, please remember the right nerve is more prone to injury. Why so? Because it is often intermingled with the branches of inferior thyroid artery. So now the recurrent laryngeal nerve, please remember it is the mixed nerve. So now the recurrent laryngeal nerve supplies all the muscles of larynx except the cricothyroid muscle. And the same, the recurrent laryngeal nerve also supplies the laryngeal mucosa below the vocal fold. Is it clear? So above the vocal fold, the sensory supply is given by our internal laryngeal nerve, and below the vocal fold, the sensory supply is given by the recurrent laryngeal nerve. Now the question is, who will supply the vocal fold? Who will supply the vocal cord? Please remember, the vocal cord is supplied by both recurrent laryngeal nerve and the vocal cord is supplied by both recurrent laryngeal nerve and internal laryngeal nerve. Sometimes the examiner may ask you one best answer. Now in that case, please go for recurrent laryngeal nerve greater than internal laryngeal nerve. Is that clear? Right. Now see this diagram. Now these are the nerves related to the thyroid gland. Now can I identify the nerve here? Yes, that is our external laryngeal nerve. Now can you see the nerve here? Yes, it is marked already there. That is the recurrent laryngeal nerve. Now see this artery here. Now this is our superior thyroid artery. So superior thyroid artery, it is a branch of the external thyroid artery. In the old edition, it is mentioned that superior thyroid artery is the first branch of external carotid. But now in the recent edition, Grace, it has been told that the ascending pharyngeal, it is the first branch of external carotid. That is a change they made in the recent edition, Grace, 42nd edition, Grace. Right. Now you see here, there is a recurrent laryngeal nerve which is closely related to inferior thyroid artery. So now inferior thyroid artery, it is a branch of, yes, very good, thyrocervical trunk. So thyrocervical trunk will give how many branches? Yes, 3 branches. I think you know the mnemonic. Mnemonic is SIT branch. Yes, very good. Suprascapular, inferior thyroid and transverse cervical. Yes, very good. So now these are the nerves related to the thyroid gland. So now see this diagram. Now this diagram is showing the various relationship of the external laryngeal nerve with superior thyroid artery. Now this classification is called Cernia classification. In type 1, the external laryngeal nerve crosses the superior thyroid vessels more than 1 centimeter above the upper edge of the superior thyroid pole. Now in 2A and 2B, the distance is less than 1 centimeter. So 2A, the external laryngeal nerve crosses a vessel less than 1 centimeter above the upper edge of superior pole. In 2B, the external laryngeal nerve crosses superior thyroid pedicle below the upper border of superior thyroid pole. And please remember, type 2B, it is of high risk, high chance of injury in 2B. Now see this diagram. Again, this diagram is showing the function of the external laryngeal nerve, internal laryngeal nerve, and the recurrent laryngeal nerve. Recurrent laryngeal nerve, I told you already, it is a mixed nerve. Yes, very good. And the internal laryngeal nerve is a sensory nerve, and the external laryngeal nerve is a motor nerve, supplies only one muscle, that is a cricothyroid muscle. Remaining all other muscles are supplied by our recurrent laryngeal nerve. Now, one more thing I want to show you here. Now, this is the Gallen's anastomosis. Now, Gallen's anastomosis is a sensory anastomosis between the internal laryngeal nerve. See, this is the internal laryngeal nerve, which is anastomosing with the recurrent laryngeal nerve. Now, this is the sensory nerve anastomosis. That is the Gallen's anastomosis. Now, these are the points you have to remember for the nerve supply of larynx.
So now that sir has told us the complete course of the vagus, what's the clinical significance of knowing the complete course of vagus? Yes, so when we know the complete course of vagus, you have the complete picture of vagus in your mind. So can you tell me that if there is any base of skull surgery that we are doing, there are chances of injury to which nerves? Yes, we are talking in relation to vagus, in relation to the larynx. So which nerves? Yes, there can be either injury to the complete branch, the complete branch, or there can be injury to the superior laryngeal nerve also. So don't think that superior laryngeal nerve can be injured only in the neck. Superior laryngeal nerve is given off in the base of skull itself. So in base of skull surgeries, in parapharyngeal mass surgeries, or in base of skull tumor surgeries, or any other surgery of the base of skull, both these can be injured separately. Now, if there is any surgery on the neck area that you're doing, especially the carotid triangle area, yes. So, what is the carotid triangle area? This that you're seeing, this is the carotid triangle area. So, in the carotid triangle, we know that there can be injury either to the superior laryngeal main branch, or there can be injury separately to either the internal laryngeal nerve or the external laryngeal nerve. And now suppose if you're doing thyroid surgeries, then which nerves can be injured? Yes, in thyroid surgeries can be injured. We just saw that where the thyroid is. So in thyroid surgeries can be injured either the recurrent laryngeal nerve or the external laryngeal nerve. And if you're talking about the mediastinal surgeries, if there is some surgery of the heart being done or esophagus in the mediastinum being done, then we know that we are dealing only with the left recurrent laryngeal nerve. So also, what's the clinical significance of knowing the supply that Sarah has just told? Yes, so we know that if there is any injury to the internal laryngeal nerve, that is purely a sensory nerve supplying the supraglottis. So the patient will have complaints of aspiration. If there is any injury to the external laryngeal nerve, that is motor to the cricothyroid. So tensing will not be there of the vocal cord. The patient will not be able to raise his pitch of voice. If there is any injury to the superior laryngeal nerve, as in the carotid triangle or in the base of skull, both the features of internal laryngeal as well as the external laryngeal will be present. Aspiration and weak voice, inability to raise the pitch of voice will be present. If there is any injury to recurrent laryngeal nerve, now, what will happen because of recurrent laryngeal nerve injury? Recurrent laryngeal nerve, if it goes, all the muscles go. So, all adduction, abduction, everything will go. Only what will be left will be the cricothyroid. And cricothyroid is the adductor also. So, it will keep the vocal cords in adducted position, that is in the median or the paramedian position. So, if there is only one vocal cord involved, so now what will happen is one will be in the median or paramedian and the other will be able to move normally. So here the patient will be asymptomatic or maybe mild hoarseness. Whereas if there is bilateral recurrent laryngeal nerve injury, both the vocal cords will be in midline and then the patient will present with stridor. And if there is complete palsy can occur only if there is injury at the level of the base of skull. Then all the nerves will go and the patient will have aphonia along with aspiration. Now, whenever questions are asked from you, what is asked is, what is the significance of remembering separately? Yes. Now, suppose a question is asked that while following base of skull surgery, patient presents with such and such a complaint. So if you know base of skull immediately, you can narrow down your options, your choices. That base of skull, I do not have to think all the nerves. I just have to think about the complete palsy, or I have to think about superior laryngeal palsy. And then you can see what the choices are. If there is aphonia with aspiration, then it is complete palsy. Where if there is aspiration, but there is only inability to raise the pitch, then it is not a complete palsy, it is a superior laryngeal palsy. Similarly, here in this patient, what we are seeing is that this patient is a patient following hemithyroidectomy, which means that which are the nerves at risk? Yes, either the recurrent laryngeal of one side and along with or the external laryngeal, or maybe both. Yes. So now we will look at the findings, the features. What are the features in the patient? The features clearly are mentioned in this question. Yes, as the left vocal cord being bowed and lax during phonation while singing high notes. So what will be the answer here? Yes, we have only two choices here. One is either the recurrent laryngeal or the external laryngeal. So what is the answer here? Yes, inability to raise the pitch. That is the external laryngeal nerve. So here, what is injured is external laryngeal. Now, suppose if there was a hemithyroidectomy following which there was a recurrent laryngeal nerve palsy, and you were supposed to ask to do endoscopy, what finding would you find on endoscopy? Change this question to make the answer as a recurrent laryngeal nerve injury. Yes, you are doing the endoscopic examination. What will you report? Yes, you will report that the vocal cord, one of the vocal cord is either median or it is paramedian, and it is not moving with respiration. It is not moving with respiration. Yes, during phonation, we need the vocal cord in midline only. So then it does not have to. But during respiration, when the vocal cords have to abduct, it is not moving. So if that was the finding that was mentioned here, then the answer would be recurrent laryngeal. So the first choice, there is injury to recurrent laryngeal of the left side. That is the incorrect choice.
Now, option B, the injured nerve accompanies the inferior thyroid artery. Again, this is false. Now, why it is false? Because the injured nerve is external laryngeal nerve that is accompanying the superior thyroid artery. Now, option C, the function of cricothyroid has got compromised. Yes, this is true. Cricothyroid muscle is affected, so patient is not able to produce high pitch sound.
This option D, this is a normal finding after thyroidectomy. No, after thyroidectomy, we are supposed to get all the nerves as normal, and the proper functioning of the larynx should be present after hemithyroidectomy. In fact, whenever any thyroid surgery is done, in the post-operative period, when you will be doing internship, you will see that always you are asked to do a IL examination or endoscopic examination of the patient. So then you should know what you are looking for when a thyroidectomy, a complete thyroidectomy or a hemithyroidectomy has been done. What are the nerves that you're looking for, and what are the findings that you will get if which nerve is paralyzed?
So to summarize, so please remember the nerve supply of larynx. So larynx is supplied by three nerves. Number one, external laryngeal nerve, that is the motor branch supplying only one muscle, cricothyroid muscle. And the external laryngeal nerve is accompanying one artery. What artery? Yes, very good. Superior thyroid artery. What about internal laryngeal nerve? Internal laryngeal nerve is sensory nerve that supplies the larynx mucosa above the vocal fold. Yes, very good. Now, what about the recurrent laryngeal nerve? Recurrent laryngeal nerve is a mixed nerve, yes, and which gives sensory supply to the larynx below the vocal cord, and it supplies all other muscles of larynx except cricothyroid. So these are the points you have to know in the anatomy aspect.
And the clinical significance of these branches and the supply in the larynx, what needs to be remembered is that at what level which nerve can be injured. Yes, at base of skull, both complete palsy as well as superior laryngeal palsy. In the carotid triangle, superior laryngeal or internal laryngeal or external laryngeal separately can be injured. In thyroid surgeries, recurrent laryngeal or can be injured external laryngeal, and in mediastinal surgeries can be injured only the left recurrent laryngeal, and accordingly will be the symptom. In internal laryngeal will be only aspiration, external laryngeal will be only inability to raise the pitch of voice. In recurrent laryngeal unilateral, patient will be asymptomatic or mild hoarseness. In bilateral, there will be stridor, and in complete palsy, there will be aphonia as well as aspiration. And if there is a superior laryngeal palsy, then combined internal and external features will be present. So coming to the next case, here we have a 25-year-old male who presents with right upper deep cervical lymphadenopathy and nasal obstruction for the past 4 months. CT shows soft tissue mass arising from the fossa of Rosenmuller. True about the patient when the tumor invades the sinus of Morgagni. So here the diagnosis is already given. When it is written here that the tumor is arising from the fossa of Rosenmuller, we know which tumor arises here. Yes, that is the nasopharyngeal carcinoma. And yes, the presenting feature is matching with that. It is a young male. So is nasopharyngeal carcinoma also seen in young? Yes, it has bimodal age occurrence. It is seen both in young as well as it can be seen in elderly. And the patient presents with cervical lymphadenopathy. That is the earliest feature, that is the main symptom that is present. In fact, the only symptom that is present in 70% of the patients when they present with this tumor. So what is asked is not the diagnosis. What is asked is that now this tumor has spread to the foramen of Morgagni. So now what will be the symptoms? So sir, can you please tell us what this sinus of Morgagni is?
Yeah, ma'am. Now, see this diagram. Now, this is a diagram showing the constrictor muscles. So, this is the constrictors, superior, middle, and the inferior constrictors. Now, these constrictors, they overlapping with each other. Now, in the interior of the pharynx, now we see the fossa here. That is the fossa of Rosenmuller. Now, we have a carcinoma there only. Now, from there, the carcinoma spread to the sinus of Morgagni. Now, where is the sinus of Morgagni? See, sinus of Morgagni is present between the base of skull and the superior constrictor. We have a gap, and that gap is called sinus of Morgagni. So now this gap transmits some important structures. Now, what are the structures passing through the sinus of Morgagni? Now, please remember, in this diagram, you are seeing clearly here. Now, this is the superior constrictor muscle, yes, and this is the base of skull, and this is the sinus of Morgagni, yes. Now we are seeing one structure here. What is that? Eustachian tube. So Eustachian tube is passing in the sinus of Morgagni. Not only the Eustachian tube, we also have some muscles. What are those? Number one, the levator palatine muscle. Yes. And we have two arteries. What are those? Ascending palatine artery. Ascending palatine artery. And number two artery is the palatine branch of ascending pharyngeal artery. So now see this diagram. Now in the sinus of Morgagni, already we've seen the auditory tube is passing. Yes. Now along with the auditory tube, see the muscle here. This is the levator palatine muscle is passing. Now along with this, two more arteries is passing. What are those? Ascending palatine artery and palatine branch of ascending pharyngeal artery will be passing. Now in the ENT textbooks, they have mentioned that the tensor palatine muscle is also passing in the sinus of Morgagni. So now please remember, now please keep the option tensor palatine muscle as a last option. Now based on the other options, you can select the answer. So now we have a gap between the superior constrictor and the middle constrictor. Now this gap transmits two structures, one muscle and one nerve. What is that? Stylopharyngeus muscle and glossopharyngeal nerve. Now the gap between the middle constrictor and the inferior constrictor transmit one artery and one nerve. Which artery? That is the superior laryngeal artery, and this is our internal laryngeal nerve. And below the inferior constrictor, now you are seeing one nerve there. What is that? The recurrent laryngeal nerve, and one artery you are seeing there, that is the inferior laryngeal artery. Now these are the various structures passing between the constrictors of pharynx.
So now that Sir has told us what are the structures that pass through the foramen of Morgagni, we know what will be the symptoms when the tumor nasopharyngeal carcinoma has gone to the base of skull in the foramen of Morgagni. Yes, because of involvement of the tensor palati, levator palati, there will be palatal palsy. So here the first choice is the patient will have palatal palsy. Is that true or false? Yes, that is true. The patient will have sinusitis media. Yes, we have the eustachian tube passing through that. So because of compression of eustachian tube, there will be sinusitis media. Yes, so that is also true. Yes, so can you tell me what this is known as? The involvement of the palate, the palatal palsy, which can, yes, lead to nasal regurgitation of food. And along with palatal palsy, if there is eustachian tube obstruction leading to sinusitis media, along with that, if there is neuralgia in the distribution of fifth nerve, what is that known as? Yes, sinus of Morgagni syndrome, or more commonly it is known as the Trotter's triad. And that is how I have asked you to remember Trotter's triad. It is seen in nasopharyngeal carcinoma. So the mnemonic is NPC, neuralgia in the trigeminal nerve distribution. P is for palatal palsy, C is for conductive hearing loss. So the trigeminal nerve distribution. So which nerve is a part of the Trotter's triad? There is neuralgia in the distribution of which part of trigeminal nerve? Yes, the same nerve that supplies the tensor palati, that is the mandibular nerve. So the mandibular nerve does not enter through the sinus of Morgagni, but sinus of Morgagni is present in the base of skull area, and very near is the foramen ovale through which is coming the mandibular nerve. So there the involvement of the mandibular nerve that leads to neuralgia in the distribution of this mandibular. This is the supply of the mandibular. So there the patient will complain of neuralgia in this area. So that is what constitutes the Trotter's triad.
Glossopharyngeal nerve enters the pharynx through this opening. Now option C is false. So glossopharyngeal nerve, which is passing between, yes, superior and middle constrictor. Yes. Now the mandibular nerve enters the pharynx through this opening. No, mandibular nerve is not passing here. Mandibular nerve supplies the muscle. Which muscle? Yes, tensor palatine muscle. It is supplying the tensor palatine muscle, but it is not entering the pharynx through this opening. So option D is false. So now what about A? So A is true, yes, and B is also true. So now in this question, both A and B are true and C and D are false.
So when we think of the nasopharynx, this is the picture that should come to our mind, and we know that where is the fossa of Rosenmuller? Yes, just behind this torus tubaris. This is the eustachian tube opening. This is the behind this we have the fossa of Rosenmuller here, and that is a deep fossa. Because of which the tumors, the nasopharyngeal carcinomas, they remain hidden for a very long time, and the patient remains asymptomatic. The only symptom that the patient presents with is just the upper deep cervical lymphadenopathy. And when we know this anatomy, we know that the tumor can go superiorly into the superiorly into the base of skull, into the sinus of Morgagni. Also, there can be multiple nerves involved in the nasopharyngeal carcinoma spread, which are asked in your exam. So, where are these nerves which can be involved? The 9th, 10th, 11th, 12th cranial nerves, they can be involved. The sympathetic chain can be involved, leading to Horner's syndrome. So, all this you need to remember in nasopharyngeal carcinoma. So, where are these nerves in relation to the nasopharynx? Yes, they are present laterally, lateral to the nasopharynx. When the tumor goes out, it goes into the parapharyngeal space. So, when you have this anatomy in your mind, so you know that where all the tumor can go and what can be the symptoms that the patient can present with. And when the patient has come with these complaints, you have to think of nasopharyngeal carcinoma. So, sir, can you tell us where the parapharyngeal space is in relation to the nasopharynx?
Yeah, ma'am. So now see the diagram here. Now this is a diagram you are seeing there. You are seeing the pharynx constrictor muscles. Now where's the parapharyngeal space? Please remember, parapharyngeal space is situated lateral to the pharynx. Now I'll show the diagram here. Now this is a diagram for parapharyngeal space. Now this is the medial boundary and this is the lateral boundary. And this is superior and this is inferior. So what is the medial boundary for the parapharyngeal space? That is the lateral border of the pharynx. Now, what's on the lateral side of the pharynx? In the lateral side of the pharynx, we have buccopharyngeal fascia. So, buccopharyngeal fascia will form the medial boundary for the parapharyngeal space. Now, what is on the lateral side? Now, lateral side, you are seeing one bone there. What bone? Yes, ramus of the mandible. Yes, you are seeing the mandible here. Mandible ramus is seeing there. And in the ramus of mandible, two muscles are attached. What are those? Yes, very good. Masseter muscle on the outer surface. And on the inner surface, yes, medial pterygoid muscle. And there is one gland which is grooving on the posterior border of the ramus of mandible. What gland? Yes, you're seeing clearly here. Yes, that is a parotid gland. So please remember the ramus of mandible, masseter, medial pterygoid, and the parotid gland, they will form the lateral boundary for the parapharyngeal space. Now, what is the superior and inferior boundary? Now, see here, this is superior boundary. So, superior boundary is the base of skull, and the inferior boundary is the hyoid bone. So please remember, parapharyngeal space is ending at the level of hyoid bone. Okay? Yes. Now see the other diagram. Now this is the diagram showing the contents of parapharyngeal space. Now by means of styloid process, we are dividing the space into the pre-styloid part and the post-styloid part, or simply anterior and posterior part. Now in the post-styloid part or posterior part, we see the neurovascular structures. What are those? This is the internal carotid artery, yes, and the internal jugular vein, and the last four cranial nerves. What are those? 9th nerve, 10th nerve, 11th nerve, and the 12th nerve. And we also see the cervical sympathetic chain. So these are the contents present in the posterior part of parapharyngeal space. Now in the anterior part, we don't have any neurovascular structures there. Now again, see this diagram. Again, this diagram is showing the parapharyngeal space. Now this is the medial side. Again, this is the lateral side. So medial side, you are seeing the pharynx. That is the lateral wall of the pharynx. That is the buccopharyngeal fascia here. And laterally, you are seeing the parotid gland. And this is our parapharyngeal space. Now, these are the things you have to know about the parapharyngeal space anatomy.
So to summarize, whenever we think of the nasopharynx, these are the structures that should come to our mind in the lateral wall, the eustachian tube, the fossa of Rosenmuller, and the tumor arising from, if arises from the fossa of Rosenmuller, will compress the eustachian tube, leading to fluid collection in the middle ear, sinusitis media. Yes, which curve will that be? Yes, the flat curve, the B-type curve. When it goes posteriorly, it can go into the base of skull through the foramen of Morgagni. When it goes laterally, it can go to the parapharyngeal space. And these symptoms, when you know this anatomy, is so simple. And now, when you know this anatomy, you know that all around are such important structures, you cannot get any surgical margin of clearance, because of which the main management of nasopharyngeal carcinoma, even if the patient has presented early in the disease, is radiotherapy. We never go for surgical excision in these patients.
So come to the next case number 6. A 30-year-old male underwent tooth extraction for dental caries. Now he presents with fever and trismus. The oropharyngeal examination is given below, and there is also swelling in the neck at the upper border of sternocleidomastoid muscle. So not true. So now in the diagram, you are seeing the medially displaced tonsil. Yes. So now that can be due to two causes. Now just now we see in this diagram, no? Yes. Now this is the parapharyngeal space or lateral pharyngeal space. Now, on the medial side of this, we have a tonsil. Yes. Now, if there is any infection in the parapharyngeal space, now what will happen? The tonsil will be moving medially. Yes, number one. Now, we also have another case. Now, that is Quinsy. That is a peritonsillar space infection. So, patient is having Quinsy here. Yes. Now, even that case also, the tonsil will be moving medially. Now, ma'am, how to differentiate Quinsy and the peritonsillar space infection, madam? In both cases, tonsil will be moving medially. And how to differentiate these two conditions, madam?
Very truly said, sir. If there is any peritonsillar abscess, that will also push the tonsil medially, and any mass in the parapharyngeal space will also push the tonsil medially. Now, you just told us the contents of the parapharyngeal space. So, there can be so many masses that can be present in the parapharyngeal space. There can be schwannomas of all these nerves, the last four cranial nerves. There can be aneurysm of the internal carotid. There can be a parotid tumor of the deep lobe of parotid. All of them will present as the tonsil being pushed medially. If there is an abscess of the parapharyngeal space, patient will have fever, patient will have trismus, the same features like Quinsy, where patient has fever and trismus and the tonsil being pushed medially. But in parapharyngeal space, always, we know that the parapharyngeal space lower boundary is the mandible. So when the abscess has, or the mass has completely filled the parapharyngeal space, only then will pressure be applied on its walls. So if it has completely filled the parapharyngeal space, we will always see external bulge here at the angle of jaw. So we will always see an external bulge here at the angle of jaw along with the tonsil being pushed medially. So whenever we have to differentiate whether it is a Quinsy or a parapharyngeal abscess, in Quinsy, this finding will be present of the tonsil being pushed medially. In parapharyngeal also it will be present. Trismus will be present in both. But an external bulge at the angle of jaw, if you see, then we know that this is a parapharyngeal abscess. And once we have differentiated that this is a parapharyngeal abscess, then we know that the incision that we will give will be different for both. In Quinsy, the incision that we give is an intraoral incision. The incision is given at the maximum bulge, or we draw a line from the base of uvula and the anterior pillar, and where they meet, just lateral to that is the incision given. Whereas in a parapharyngeal abscess, the incision that is given is a horizontal incision below the lower border of mandible. In fact, whenever we give any incision below the mandible, for example, while excision of the submandibular gland, or for Ludwig's angina, again we give a midline incision below the lower border of mandible. Always it has to be at least 2 to 3 centimeters below the lower border of mandible. And why this is again a question. Yes, so that we do not injure the marginal mandibular nerve. Sir, can you show us where the marginal mandibular nerve is?
Yes. Now, see the diagram here. Now, this is the marginal mandibular nerve. It's a branch of facial nerve. See, that is passing below the angle of mandible, and that is closely related to the facial artery and the facial vein.
Yes, thank you, sir. So we just saw that the marginal mandibular nerve dips down and then comes up with the facial vessels. In fact, if you want to see where your marginal mandibular nerve is, you can just palpate the pulsations of the facial artery. You will be able to feel. And we do not want to injure this nerve at all. Why not? Because it supplies the lower lip. So what will happen if you injure it? Yes, this part of the lower lip, when the patient is talking, when the patient is smiling, this will not move down, and there's a very bad cosmetic deformity that you're giving to the patient is not going to leave you. Yes, so that is what we need to remember in the difference between a peritonsillar and a parapharyngeal abscess. So what is ours is not true. Let us see the first choice. Abscess is in between the tonsillar capsule and the superior constrictor muscle. Yes, so here we are seeing that the abscess is a parapharyngeal abscess. There's external swelling in the neck also. So here the abscess is not in between the tonsillar capsule and the superior constrictor. In between the tonsillar capsule and the superior constrictor is the peritonsillar space. So that will be the space where Quinsy arises from. So this is the false option. This is false. The next choice we have here, the contents of the space is internal jugular vein. Yes, internal carotid, yes. 9, 10th, 11th, 12th cranial nerves, yes. So this is the true choice. The space is separated from the infratemporal fossa by masticator muscles. Yes, this again is the true choice. So here we can have a look here. Sir has beautifully explained earlier also. So here this is the nose, and the base of skull goes slanting down like this here. So we have behind the nose, behind the nasal cavity, we have the nasopharynx in this area, below which we have the oropharynx, and lateral to both the nasopharynx and the oropharynx, this space that we are seeing is the parapharyngeal space. And here anteriorly, the parapharyngeal space is separated. This is the pterygoid plate. Here we have the masticator muscles. So anterior to that is the infratemporal fossa, and posterior to that is the parapharyngeal space. So yes, it is separated from the infratemporal fossa by the masticator muscles.
Option D, it communicates with the submandibular and the retropharyngeal space. See the diagram. Now this is the cut section of neck we are seeing here. Now this is the buccopharyngeal fascia, that is the part of the middle layer of deep cervical fascia, and behind that alar fascia you are seeing there. That is a part of the posterior part of deep cervical fascia. Now between these two we have a space, and that is called as retropharyngeal space, this one. Right? Now behind the alar fascia, between the alar fascia and the prevertebral fascia, now we have this space, and that space is called as danger area of neck. So ma'am, do we have any connection between the parapharyngeal space and the retropharyngeal space?
So sir, we just saw here that this is the parapharyngeal space, and just behind the pharyngeal wall, just behind the buccopharyngeal fascia, which covers all the muscles, we have this area. This is the retropharyngeal space. So there is no differentiation. There is nothing that separates the parapharyngeal space from the retropharyngeal space. Also, below here, we know that the parapharyngeal space extends down till the level of the hyoid bone. Yes, till this level, hyoid bone. And here anteriorly, we have the submandibular space. So the parapharyngeal space also communicates with the submandibular space. So this is one space. Abscess of this space is very dangerous, because any infection from here can easily go to the submandibular space. It can easily go to the retropharyngeal space. Nothing separates them as such. And any infection from these areas, also retropharyngeal or submandibular, can very easily come into the parapharyngeal space. So yes, it communicates with all these spaces. So the last choice is also a true choice.
So to summarize about the parapharyngeal space, so please remember the boundaries of parapharyngeal space. Medially, you have the buccopharyngeal fascia, that is the lateral part of the pharynx, and laterally we have the mandible bone, masseter, middle pterygoid muscle, and the parotid gland. Superiorly, the base of skull, inferiorly to the hyoid bone. Now, what are the contents? In the post-hyoid part, we have neurovascular structures. What are those? The internal carotid artery, the internal jugular vein, 9th nerve, 10th nerve, 11th nerve, 12th nerve, and the cervical sympathetic chain. Right. Now, these are things you have to know about the boundaries of parapharyngeal space.
And coming to the clinical significance of parapharyngeal space, we have so many structures in the parapharyngeal space. So there can be many masses that arise from this parapharyngeal space, and any absence of the parapharyngeal space or any masses of the parapharyngeal space will push the tonsil medially. And not only will the tonsil will be pushed medially, also we will see external bulge at the angle of jaw. So whenever we are seeing the tonsil pushed medially, whenever the patient has come with with this complaint of difficulty in swallowing, trismus, and we are seeing the tonsil pushed medially, so don't immediately jump on the diagnosis that this is Quinsy. Always aspirate and see whether this is a pus that you're aspirating or not, because this can be a bulge from any mass from the parapharyngeal space, which can be aneurysm of the carotid, which if you do not aspirate and just give an incision, there can be a carotid blowout and you can lose the patient on table there itself. And this parapharyngeal space is a very, very important space because it communicates with all the nearby spaces, because of which any infection can come here. And as you told us, the lateral boundary is the masticator muscles. The medial pterygoid is very close to this space, because of which any abscess or any mass here can lead to trismus. There can be trismus, difficulty in opening of the mouth in parapharyngeal abscess. So these can be the features: pushing of tonsil medially, external bulge, trismus can be the features of the parapharyngeal space masses. And when there is an abscess there, we know how we give the incision, and the marginal mandibular nerve has to be protected there by giving the incision 2 to 3 centimeters below the lower border of mandible. So starting with the next case, a 55-year-old female presented with the complaints of pain in the right side of face, presenting as a shock-like sensation that aggravated on brushing and washing the face. She also gave history of decreased hearing and tinnitus in the right ear since more than a year now, but that was not disturbing to her. She had no vertigo or neurological alterations. Her physical examination was normal, with intact and normal bilateral tympanic membrane, no palpable lymph nodes. Her pure tone audiometry showed sensorial hearing loss in the right ear. Her left ear was within normal limits. An MRI was done, which revealed an enhancing mass in the CP angle, following a true about this condition. So there are no surprises here. It is very clearly given the MRI has been done, which is showing an enhancing mass in the CP angle, and with additional features of hearing loss, features of tinnitus. All this very clearly points that the diagnosis of the patient here is acoustic neuroma, which is the most common benign tumor of the CP angle. Sir, can you please tell us about the CP angle?
Yeah, ma'am. Now, CP angle, that is cerebellopontine angle, it is a potential space in the posterior cranial fossa. Now, what is the boundaries of CP angle? See, in front, we have the posterior part. This is a temporal bone. I hope you know that. This entire thing, that is a temporal bone. Now, the anteriorly, we have the posterior part of temporal bone. Yes. Now, laterally, this is a petrous bone. This is petrous bone. So, laterally, you are seeing the petrous bone, right? Now, medially, this is the view of cerebellum and the brainstem. Now, medially is the lateral part of the brainstem. This is midbrain, this is pons, and the medulla. So, medial boundary is the lateral part of the brainstem. Now, posteriorly, we see cerebellum, and superiorly, we see the middle cerebellar peduncle. This is middle cerebellar peduncle, and inferiorly, the cerebellar tonsil. Now, this is the boundary of the cerebellopontine angle. Now, what are the contents of CP angle? That is very important. Now, see this diagram. Now, here you are seeing the CP angle, cerebellopontine angle. Right. Now, see this diagram. Now, this diagram, this is the posterior view of the CP angle. Now, can you see this one? This is the cerebellum we are seeing here. And in front of that, this is pons. Now, we are seeing CP angle from behind. Is that clear? Right. Now, we have this fossa here. Now, this angle is called, that is the CP angle. Now, what are the contents of CP angle? Okay. Now, see this diagram here. Now, what are the contents of CP angle? Now, again, this is the posterior view. This is the cerebellum. Now, can you see this one? Yes, that is the flocculus. That is flocculus, part of cerebellum. And what are the nerves you're seeing here? Now, can you see the nerve here? Yes, that is the trigeminal nerve, a content of CP angle. And just below that, now, can you see this nerve here? Yes, that is the fascial nerve. Now, can you see this nerve? And that is our eighth nerve. And can you see the artery here? Now, this artery is anterior inferior cerebellar artery, ICA artery. And below that, you are seeing here, that is the posterior inferior cerebellar artery. Now, in the lower part of CP angle, we also see these three nerves here. Now, this is the ninth nerve, and this is the vagus nerve, and this is our accessory nerve. Is it clear? Now, we also have one more nerve there. That is the abducent nerve. See, abducent nerve, we are not able to see here. That will be arising close to the apex of the petrous temporal bone. That is, we are not able to see here. Right? Now, we see the this foramen here. Now, can you see the structure here? Yes. Now, that is our internal auditory meatus. Now, the internal auditory meatus will transmit structures. We're going to see that later. Yes. Now, see the other diagram. Now, again, the same diagram only, CP angle diagram. And here we are seeing the structures, nerves clearly here. Now, from above, we're going to see now. Now, this is the trigeminal nerve. Can you see here? Now, this is CP angle. This entire thing is CP angle. So, we zoom the CP angle and we are seeing here. So, now, see here, this is our, yes, trigeminal nerve. Again, we're not able to see the abducent nerve here. And this is the seventh nerve and this is the eighth nerve. And you're seeing the artery here. That is the anterior inferior cerebellar artery. And can you see the nerve here? This is the ninth nerve. This is the 10th nerve, vagus nerve. And this is our accessory nerve, 11th nerve. And can you see this nerve here? That is the 12th nerve. So 9th nerve, 10th nerve, and 11th nerve. So they're coming out of the cranial cavity. So through this foramen, that is our jugular foramen. Is that clear? So what are the contents of CP angle? Number one, flocculus of cerebellum. What are the arteries you see here? Anterior inferior cerebellar artery, posterior inferior cerebellar artery, sometimes superior cerebellar artery, and the labyrinth artery. These are the present here. Now, what are the nerves present from above downwards? Number 1, trigeminal nerve. Number 2, abducent nerve, and then facial nerve, vestibulocochlear nerve, 8th nerve, glossopharyngeal nerve, vagus nerve, accessory nerve, and the 12th nerve. And this is the structures passing through the internal auditory meatus. So internal auditory meatus, we're going to divide into superior part and the inferior part by means of this falciform crust. Now superiorly, we have Bill's bar, which is separate the anterior and the posterior part. Now superior vestibular nerve and the facial nerve, it is passing through the superior part. Inferiorly, the inferior vestibular nerve and the cochlear nerve. Is that clear? Right. Now these are structures, various structures passing through the internal acoustic meatus. And please remember the mnemonic 7 up and coke down. So which means that 7th nerve is above and the cochlear nerve is behind. So these are structures, the nerves passing through the internal acoustic meatus. Now, ma'am, the acoustic neuroma is most commonly arising from which of these following nerves, ma'am?
Yes, sir, explained very beautifully. Now, acoustic neuroma arises from the vestibular nerve. And if in the choice is given both superior and inferior vestibular, then we have to go for the inferior vestibular. This is the more common site of origin of acoustic neuroma. And when it is arising from here, we can know that the just adjacent to it is the cochlear nerve. So it will compress the cochlear nerve, leading to sensorineural hearing loss. So any elderly who is presenting with sensorineural hearing loss, we need to rule out acoustic neuroma. So now, students, you must be thinking that elderly usually have sensorineural hearing loss, right? Yes. So what is that known as presbycusis? So then, do we investigate every elderly for acoustic neuroma? No. Presbycusis is always bilateral. So if any elderly is presenting with unilateral sensorineural hearing loss, then we need to investigate for acoustic neuroma. And though we have other nerves in the vicinity, we have the facial nerve, we have the, it is rising from the vestibular nerve. There are no features because of involvement of these nerves, even when the tumor completely fills the internal acoustic meatus. Till the tumor completely fills the meatus, there is only one feature, and that is sensorineural hearing loss and tinnitus. Why no feature because of facial compression? Yes, because facial, it is a mixed nerve, it has got motor and sensory parts. Whenever the a mixed nerve is compressed from externally, the motor part takes a very long time to get involved. The sensory part gets involved early. The sensory part is more sensitive. So which means that we are not going to see any feature because of involvement of the motor part of facial. We will not see any facial palsy. We might see some feature because of involvement of the sensory part of facial. So what is the sensory part of facial? Yes, that is supplying the posterior part of external acoustic meatus. And there will be hyposthesia or anesthesia in this part. That is what is known as the Hitzelberger sign. Yes, that is the Hitzelberger sign. The Hitzelberger sign. Yes, though it is very commonly asked, it is totally irrelevant clinically because it is seen in very few people, and moreover, if any person has anesthesia or hyposthesia in this part, he never comes with this complaint. It is only when we are ruling out acoustic neuroma and we want to see whether there is anesthesia in this part or not, we can try to elicit it. And even if we try to elicit it, in 75% of the population, of acoustic neuroma, it will not be present. It will be present only 25%. And also, though this tumor arises from the vestibular nerve, there is no feature because of involvement of vestibular nerve. Vertigo is not present in usually in these patients because this is a very, very slow growing tumor. As the tumor grows and causes vestibular decompensation, the central compensation and compensation from the opposite side continues at the same time, because of which there are no features of vertigo also, unless and until there is a sudden growth of tumor or hemorrhage within the tumor where compensation cannot occur immediately. Which means that the feature is only because of compression of the cochlear nerve. So now when the tumor grows out of the internal acoustic meatus into the CP angle, the next features will be because of the involvement of these structures in the CP angle. So at the upper pole, we have the fifth and the sixth nerve. So patient can have loss of corneal reflex because of involvement of the fifth nerve, trigeminal paresthesia. Patient can have diplopia because of the sixth nerve involvement. At the lower pole, we have the 9th and 11th cranial nerve involvement. There can be later on cerebellar compression. So when we know the anatomy of the internal acoustic meatus and the CP angle, then we know all the features of the acoustic neuroma, how the tumor is growing, where it is growing, what will be the next features, and if the coronary reflex is involved, it means that which nerve is involved, where it is involved in the CP angle. Yes, at the upper pole, that indicates that the tumor has gone into the CP angle. The tumor is at least 2.5 centimeters in size.
Yeah, thanks, ma'am. And let's see the options here. Now, option A, the pain in the preauricular region is due to the involvement of fascial nerve. Now, again, that is false. That is due to involvement of trigeminal nerve. So, option A is false. Right. Now, ptosis is usually present in these patients. Again, this is false. So, ptosis is mainly due to the involvement of oculomotor nerve. I told you already. P, PD, PDO. Yes. It is most commonly involves the vestibular division. Yes, it is true.
The D choice is loss of corneal reflex, which occurs early in the course of this disease, is because of involvement of the fascial nerve. So, sir, can you tell us something about the corneal reflex?
Yeah, ma'am. Sure. So now this is the corneal reflex. So corneal reflex, please remember the afferent and efferent of the corneal reflex. The afferent of the corneal reflex is the ophthalmic division of trigeminal nerve, and the efferent of the corneal reflex is the temporal branch of the facial nerve. Now see the option D. The loss of corneal reflex which occurs early in the course because of involvement of facial nerve. So just now we discussed about the afferent and efferent of the corneal reflex, that is ophthalmic nerve and the facial nerve. Now, ma'am, I have two doubts. Number one, here the loss of corneal reflex is due to which nerve, madam? Whether it is facial nerve or ophthalmic nerve. That is the first doubt. And second doubt, now why it is occurring as the early in course, madam? Now these two doubts I have. Any reason for that?
Yes, sir. There is the corneal reflex is both by the trigeminal as well as the facial, but we have just seen that whenever the motor nerve gets compressed, the facial gets compressed in the internal acoustic meatus itself. But when it is compressed, the motor features are seen very late. So the corneal reflex efferent, which is the facial, that is the motor part. So the sensory part of the facial will not lead to loss of corneal reflex. The sensory part which leads to loss of corneal reflex is the trigeminal nerve. So that is why when the corneal reflex is absent, it is because of involvement of the fifth nerve that is at the upper pole of the tumor. Later on, in very late in the course, the facial nerve can be involved, and then the facial muscles can be involved. And anyway, when the facial muscles are involved, we never look for corneal reflex. Corneal reflex is never is never a test for the facial nerve. When we look for facial nerve palsy, we can have a look at the face of the patient and we can tell that the patient has facial nerve palsy. We do not have to go specifically for corneal reflex. So when we are doing testing corneal reflex, otherwise also, it is usually a test for the trigeminal nerve. And here, when the tumor goes intracranially into the CP angle and the upper pole involves the trigeminal nerve, the earliest feature because of involvement of the trigeminal nerve that we see is the loss of corneal reflex.
So now option D is also false. So now the true statement is option C is true. Right. So now to summarize about the acoustic neuroma. So please remember the boundaries of cerebellopontine angle. Yes. And please remember the contents of cerebellopontine angle. Now what are the contents? Number one, flocculus of cerebellum. Now what are the arteries you have to remember? Number one, anterior inferior cerebellar artery, posterior inferior cerebellar artery, sometimes superior cerebellar artery, and the labyrinthine artery. Now, what are the nerves present in this cerebellopontine angle? Number one, our trigeminal nerve. From above downwards, I am saying. Number one, trigeminal nerve. Number two, yes, abducent nerve, and then facial nerve, and then vestibulocochlear nerve, and then below 9th nerve, 10th nerve, 11th nerve, and 12th nerve. Now, out of all these structures, the acoustic neuroma or cerebellopontine angle tumor is most commonly arising from, just now madam told, that is from inferior vestibular nerve. And the tumor can compress any of these structures and they produce some symptoms. Now, these are things you have to know about the cerebellopontine angle from the anatomical point of view.
And clinically, the CP angle is very, very important to us. Why? Because of its proximity with the ear. We know that the internal acoustic meatus is present in the pituitary bone, and that is very close to the CP angle. So whenever there is any involvement of the fifth nerve, of the sixth nerve in conditions of the ear, so if the patient of condition of the ear is coming with diplopia, If the condition of a patient of the ear is coming with loss of corneal reflex because of trigeminal nerve involvement, so we do not have the sixth nerve anywhere in the ear. So immediately we know that which is the area involved. It is the petrous apex area. So if it is an infection that has been given in the question, then it can be a petrositis. Or if it is a presentation like this, elderly with sensorineural hearing loss, then we have to think of acoustic neuroma. And when we know about the CP angle, we can very beautifully know each and everything about the acoustic neuroma, where it is arising, how it is going, what are the symptoms that will be present, and that you need not ratify at all. So here comes the significance of the anatomy. So that's all for today. And yes, to read about anatomy and see the anatomy is a treat for any surgeon. And I hope it was beneficial to you also. So all the best. Do well.
So thank you so much, guys. See you soon in the next session. Wish you good luck. Best wishes.